We're going to have a few highlights first, and then we'll have a panel discussion. The first highlights will be by our ultimo leader, Holm Graessner, to talk about key Solv-RD achievements. Please, Holm.
Yeah. Thank you, Han. So I really appreciate to present the key achievements of Solv-RD here and now. And it's kind of summarizes what we heard over the last 2 days. So it's really a pleasure to present these key achievements. And I would like to, I know you all know, but I would like to point out, starting at the start of my presentation with that diagnosis is still a main health issue for these patients. And you know all that the diagnostic journey takes years. There are a large fraction of patients which are misdiagnosed. We have a high impact of misdiagnosis. And we also know all that about 20 to 70% of genetically tested patients, for those the molecular cause cannot be confirmed. But what I wanted to show you is the patient journey of a typical rare neurologic disease, which is hereditary spastic paraplegia. And in the patient journey, which you see on the slide, you see how large a space diagnosis still takes. So that emphasizes the importance of diagnosis for rare diseases. So the first key achievement I wanted to show you has been shown already. That's the infographic on the diagnostic patient journey. And this diagnostic patient journey has been done by the Community Engagement Task Force, which was established in Solv-RD and is now being available in 24 European languages. I think this is really something to use for information purposes of patients, but also of non-experts in the healthcare sector. All right, so when we started Solv-RD, what were the key challenges we identified? So we identified 3 key challenges. So first, accessibility of unsolved rare disease cohorts with comprehensive genetic and phenotypic data. Challenge 2 was new and improved approaches for the discovery of novel molecular causes. And challenge 3 was translate discoveries to impact clinical practice. So this is our first main achievement. Through collaboration, the involved European reference networks provide a pan-European framework to share and analyze clinical and omics data and interpret analysis results. So looking at who actually participates in Solv-RD, you see that we don't really talk about a project anymore. It's really a pan-European Solv-RD network, which at present includes 6 European reference networks and 2 undiagnosed rare disease patient programs. And it adds up. So we have 23 official Solv-RD project partners, 39 associated partners, 48 collaborators, and in total, over 500 clinicians which actively contribute to Solv-RD. So the next main achievement is kind of the cohort structure we introduced horizontally in addition to the European reference networks we use to not only collect the data, but also to have the respective clinical and genetic expertise in place to do the analysis and the interpretation. So we introduced 4 cohorts. One is the unsolved cases cohort, which is the cohort being used for the reanalysis, about which you will be hearing a lot more through the next talk, which will be given by Alex Heuschen. And then we have 3 cohorts, 2, 3, 4, which are associated with the novel omics approaches, which are, by and large, linked to specific cohorts from the European reference networks, again, pointing out how important and how basically the European reference networks are and where for the Solv-RD endeavor. So we have been building, and we have been hearing that a bit already over the last 2 years, a quite incredible and I think unique data resource. So as regards cohort 1, we have data sets of close to 23,000 whole exome and whole genome data sets. And in terms of cohorts 2 and 4, we have a bit more than 4,200 biosamples from a bit more than 2,700 participants, or summing up to a bit more than 2,800 omics experience already released, and there will be more. And we heard the data number already yesterday, so which is, I think, really incredible. So all the data we have been collating and producing in Sofady amount up to, at the moment, a bit more than 800 terabytes, and will be reaching more than 1,000 terabytes at the end of Sofady, which is the second largest project in EGA at the moment. So we have also establishing a data workflow, and I think all clinicians, all scientists involved, and bioinformaticians, of course, know that workflow very well. So first, it was about consenting and reconsenting patients, which is the basis for all we do. So without consent, nothing will be done. Then data was collected through the genome-phenome analysis platform of RDConnect. The data were submitted in terms of standardized data sets, so genomic raw data, phenotypic data, and experimental metadata. The same standard analysis pipeline and workflow was being done for all genomic data. Then the raw data, new alignments, variant calls together with the phenotypic data and pedigrees were submitted to EGA. So amounting to this huge amount of data we have already at present. The EGA shared the data with local analysis cluster, which was one of the decisions we took to really facilitate and enable the analysis, and which is actually working. So the local analysis cluster, I think, in terms of analysis, are the key to having a successful analysis in Sofady. And then data could also be accessed through the Sofady sandbox. And if you wanted to track what is being happening in Sofady in terms of data, in terms of experience, you could go to the RD3 database, because that was is the metadata database of Sofady, providing that kind of overview. So second achievement. Sofady is living up to its ambition and expectation regarding improvement of diagnostic yield. And in order to prove that, I went back to the planning stage of Sofady. And I found that when we wrote the application, we put into the application the following. Sofady will significantly increase the diagnostic yield from 50 to 70% by conceptually developing novel strategies using novel molecular approaches. And for the respective cohorts, we foresee an increase of diagnostic efficiency as follows. And I just wanted to point to the reanalysis figure we anticipated, and we anticipated an increase of 3 to 5%. So, as you will hear much more about at the next talk, and with the next talk, the expectation with regard to reanalysis have been exceeded. So we really have now an actual yield of the data we collected, and of course, also the statement in the proposal can just refer to the data collected. We have an actual additional yield of 12.5%. And also, we see that in the next data freezes coming now to the reanalysis, the respective overachievement, so to say, is being achieved. And for the novel omics, we now see that quite a number of cases are being solved. And we have been organizing a Solverton workshop quite recently, really to bring together data scientists, clinicians, and geneticists to hands-on working on solving rare diseases and respective patients. And this is actually reflected in the two-level expert framework we use. And Olaf referred to that already. So we have a two-instance expert framework, which uses on the one hand the data analysis task force, and on the other hand the data interpretation task forces. In the data analysis task force, or the data expert collaborate in working groups and analyze the data. And the data interpretation task forces not only collate the data, but interpret the data and also have EN-specific filtering and interpretation. And just from the numbers you see here and here, you can imagine what kind of collaboration effort was needed to actually get that in place, but it works. So the two-level expert framework really delivers on European scale. And that's the workflow, how it was done and is being done for the reanalysis. So there is a central analysis for each different variant type undertaken within the DETF. Then the general filters are being applied over all data sets being collected with respect to variant quality, control population, allele frequencies, and predicted consequence. Then there's a third step in which EN and disease-specific filters are being applied, and we have EN-specific gene lists for the reanalysis. And then finally, the analysis is being complemented by respective work being done locally or on smallish projects. So finding a new variant or finding a new gene is not enough. You need the respective functional validation. And in order to provide the opportunity to do so, we installed a matchmaking initiative. And this matchmaking initiative actually uses the blueprint of the Canadian Rare Disease Models and Mechanisms Network. And just from the quite elaborative flow. So we received 65 applications of clinician and geneticists which found new genes to be validated. We also then received respective application from basic scientists who had the expertise and the model system to do the validation. And in the end, we could actually seed fund 33 projects which are doing the validation. And we see from the respective collection of model systems being used that it was not just one model system, but a variety of model systems. And you also see that in terms of where the actual basic science experiments were done, that it really spans the entire globe. So it's really now a, not any longer European, but I think it's rather a global rare disease mechanisms and model network, which proved quite successful. So I'm coming to the third and last part of my presentation. So in terms of achievements and impact, SOPHADI is already and will be bringing about impacts on multiple levels with regard to quality of life, clinical practice and research of rare diseases, and rare disease patients. And the first thing I wanted to point out is that through collaboration, so SOPHADI as a collaborative, European collaborative framework is actually bringing about benefits for all the countries which participate in SOPHADI. And this is just showing you the solving rate of the countries which have contributing data sets to the SOPHADI data analysis effort. And you see it reaches from Belgium to United Kingdom and in between a number of further countries, and they all benefit to different levels, and depending on also what kind of heterogeneity the previous exome or genome sequencing had from the collaborative effort being done in SOPHADI. I just wanted to show you 3 impact figures of SOPHADI, which I think also quite nicely show how far SOPHADI reaches. So you heard the 12.5% already Of these patients, we could find the diagnosis for. The diagnosis was informative in terms of actionability for 15%. And I think we also showed that SORVA-D is kind of cost effective because per included individuum in the reanalysis being done, just 48 minutes of expert time was being spent. I think you're all aware how important standards are, in particular in the diagnostic and clinical setting. And in order to provide that standard for the application of whole genome sequencing in rare diseases, we developed an expert opinion-based recommendation for whole genome sequencing and diagnostics for rare diseases. This was being done in collaboration with EuGenTest and the European Society of Human Genetics. Then, of course, we also focused on communication of genomic results, because it's not enough to find and to validate the respective new variants in genes, but also to communicate that to patients. And it was being done in a co-design study. And what we saw from the study being done in a co-design study is that, in particular, the identification of post-test care has been a priority, not only for families, but also for the respective involved healthcare professionals. So you heard about the Twitter volume already, which I think is also a major achievement. Going the next step, linking, on the one hand, genetic variants in genes with, on the other hand, respective available treatments for which evidence is there. So we have been submitting a number of papers, really numerous papers actually, but we have submitted just 2 paper bundles. So one paper bundle right after the first success stories were in place, and we submitted that to the European Journal of Human Genetics in 21. And then the second bundle is just being submitted now. So the flagship paper, and Alex will be talking more about that, is now being under review in Nature Medicine. And I would like to finish what Tim has emphasized as, I think, not really the future, but I think the link of the present and the future. So the step from diagnostic genomics to interventional genomics. And I think Tim nicely showed that it's really feasible to develop mutation-specific ASO therapies, to do that in an academic context, and then ultimately to treat the respective patient and patients. And I wanted just to give you an impression of the patient now being treated. So first being treated in Boston, and now being continued in Tübingen. And that's the boy just now being treated in Tübingen. And with that picture to remember, I would like to finish my presentation. I would like to acknowledge all these SORVA-D folks. I would like to apologize for all those I didn't present the achievements on, because there are numerous ones I didn't present. I just took a few to present today. And I want to thank you all for your work on SORVA-D. Thank you.